Clevenger. I'm a clinical professor and associate dean for clinical and community partnerships in the School of Nursing. I'm also the clinical director and a nurse practitioner at Emory's Integrated Memory Care Clinic, and that's what I'll be speaking to you about this evening. I want to begin with the story of Sarah. Sarah's mother, Bonnie, had been showing some changes. She had been using one word for another. She had been having some trouble executing things that required multiple steps. But at the same time, Sarah's father was going through care for advanced cancer. And so they thought, things are difficult for everyone right now. And after Sarah's father passed away, it became evident that Bonnie's symptoms were not improving. In fact, they were progressing. And she knew that they had a problem. And so Sarah brought her mother to Emory's clinic that's associated with our Alzheimer's Disease Research Center. And they confirmed for her that Bonnie had dementia syndrome caused by a disease affecting her frontal lobe. And things began to change. And so Sarah, who lives in Decatur, was trying to see her mother more often, who lives in Marietta, if you're familiar with the region or you remember. And she called every day to check on her. She tried to do things from a distance that could support her as much as her mother would let her, which was not much. And on one of those days when she made the call, Bonnie was very upset because she had fallen outside while walking her dog, Howard. Howard, who Sarah still described to me just a few weeks ago as both huge and sweet, black Newfoundland. So Sarah couldn't quite tell just how severe the injuries were, but she was quite concerned, and so she rushed, as much as anyone can, across town to see her mother. And an hour later she arrives, and her mom does look pretty banged up, but that's not the only thing she notices. She also notices that the pill box that she had filled at her last visit, while never something that was perfectly adhered to, was completely full. That the meals she had had delivered to her mother's house were still in the refrigerator, rotting. That the car in the garage had new scrapes that had not been there the last time she checked. And that it was probably helpful to take Howard out because it was obvious he had not been out as often as he needed to be. And she knew now things were serious. So she calls her mother's primary care. She gets an appointment that day. And she gets into the primary care office, and this, for the first time, they allow her into the exam room with her mother, because up until this point, she had been relegated to the waiting room, citing issues with patient privacy. But in this visit, the primary care team realized they probably could not treat Bonnie without Sarah being present, and so there she was. And they addressed the question, a critical one, how severe were the injuries? Did there appear to be a need for any higher level of care? And that's very helpful. But Sarah also had questions like, can my mother still live alone? If she can't be alone, could someone come into the home? Would she let them come into the home? Where do you find people like that? If they come in, would she let them stay? Do they help with those medicines that I found in the pill box today? Are they at that level? Would my mom leave? I'm not sure how I would negotiate that. Should she still be driving? My friends are talking about hiding the keys. I can't imagine doing something like that to my mother. And those questions were not able to be addressed in that visit at primary care. And on her drive home, she's thinking, I'm going to have to make a change. And she remembers that she received a letter from our Integrated Memory Care Clinic through her neurologist telling her that Bonnie was eligible for a new primary care practice. And the primary care was delivered by nurse practitioners who know what frontotemporal dementia is and how to provide primary care to people with it. And she makes an appointment. We see her that week. When Bonnie comes, we did the same thing with her that we do with all of our new patients. We see them both together and separately. We see them together to initiate the visit, and then for things that Sarah wants to tell us but doesn't want to be disrespectful in front of her mother, we do that separately. We begin with some important questions, like first of all, what's really important to Bonnie right now? What means the most to her? What is her level of awareness around her capacity? And what are her resources? Both what is she able to do independently, what does she need help with, and what does she have resources to support? And the same questions to Sarah. What is most important to her right now? At the visit, I'm the nurse practitioner, and so I'm focused on the medical care. I'm trying to answer those questions with my cognitive evaluation to determine exactly where we are in terms of her stage of cognition and thinking, and her ability to do all of these things like manage medications, drive that car. How would she respond if she were home alone and a home emergency happened, like a kitchen fire? The licensed clinical social worker is going to see them. She's going to offer therapeutic support, mostly to both of them, but mostly to Sarah. While she's doing that, I'm engaging in the rest of my visit. I'm interested in the medications. Are some of these medications actually creating additional problems with her thinking? Are some of them now inappropriate and can be unprescribed? I'm interested in her walking and her balance and her foot health and what's going to make her at high risk for further falls and which of those could I potentially mitigate. And I'm also interested in her congestive heart failure, her aortic narrowing, her chronic kidney disease, her high blood pressure, and her irregular heart rhythm of atrial fibrillation. Our registered nurse takes a look at the abrasions, cleans them up, nothing in terms of infection going on, and also provides foot and nail care. During my exam, I found that she had some earwax that was clogging her ear, which also throws off your balance. We removed that by the registered nurse as well. The registered nurse identifies preventive care down the road for immunizations that are appropriate, a bone density scan. Ultimately, it was the nurse who found Howard his new home with a couple that was familiar with Black Newfoundlands and was really happy to have another one. And our patient care coordinator who answers our phone line makes sure that Sarah, like all of our other caregivers, get direct access to our clinical team, not the call center during working hours. After hours and weekends, it's the nurse practitioners who answer the phone. And that clinical model that I'm describing to you is Emory's Integrated Memory Care Clinic. It's a dementia-sensitive primary care practice. It was conceived by 2 former caregivers who also funded it, and 2 nurse practitioners, and it's been incubated at Emory for the last 5 years, like a living lab. We provide not only the medical, but the social and emotional needs and support that families need as they're trying to navigate these tough decisions and coordinate all of these services in the new world of aging and community services. The thing about dementia is that syndrome and the diseases that cause it are part of a group of diseases that we say have no disease-modifying treatment. And that's a nice way of saying no cure. But no cure does not mean that there's no help. It doesn't mean there's no treatment, and it certainly doesn't mean there's nothing we can do. At Emory, we're in this practice trying to show the rest of the world exactly how much we can do, because dementia is not rare. Almost 6 million Americans have dementia. It's the 6th leading cause of death, and the only one in the top 10 that's increasing in prevalence, not decreasing. So there's a lot of help that's needed out there. One of our other caregivers gave us some feedback recently in terms of how successful are we in providing that help. And with his permission, I'm going to use his words. So Jack is a spouse caregiver. His wife of more than 60 years has Alzheimer's disease. And she's recently moved to a higher level of care, a nursing home. And he's processing that change for them. And honestly, he shared with us he's in a good place about it. He feels like she's getting good care. He's able to sleep at night again. He can think a little bit. And he was reflecting on his past few years with us. And he said, I would imagine the story of my experience is not unlike many of the families who work with you. Most of us arrive on your doorstep looking a little more than a little lost, in a very dark place, and feeling alone in the world. And you all take our hand, turn on the light, show us the way forward, and make sure we know we're not alone. And that feedback was very powerful because that was precisely our intent. Thank you.